Thank you. So the next speaker is Dr. Elisabeth Waagensen. She is a medical doctor and a master in disaster management from the School of Global Health at the University of Copenhagen, and is currently a consultant for the Migration and Health Program at the WHO Regional Office of the EU. You are going to tell us something about public health implications of refugee and migration movements in the WHO European region. Thank you.
Good morning, everyone. Thank you for having me. Thank you, Brigitte, for inviting me and having us here today. On behalf of Dr. Santino Severoni, who is unable to attend today, I also bring my warmest regards to all of you who I think many of you know him. And thank you also to Mr. Ryan for the presentation that you've just done, introducing us indeed to the many elements that go into the subject that we are talking about today, particularly on the perspective of the European Union, whereas I'm talking about the WHO European region. So the WHO European region, I have to say, is slightly larger. We consist of 53 member states. We go as far east as the Pacific Ocean. We encompass Russia, Azerbaijan, Kazakhstan, all of those nations. So we in fact serve 920 million people. And so the perspective is slightly different, and the demographic of the group that we're talking about when we talk about refugees and migrants is also slightly different if you just look at the European Union perspective. So the diagram that I have, or the graph that I have here, shows that about almost 10% of the population in the WHO European region is indeed a migrant. And when we say migrant, I want to start off by saying this is a discussion that certainly is valid within the academic world as well. We talk a lot about the nomenclature that we use when we talk about refugees and migrants. And refugees have a very specific set of laws that they fall under. The UNHCR definition is what we use. And we use the IOM definition for a migrant, which is a much broader term. And that's certainly something that can be discussed, and it is discussed on the world stage. How do we define these groups of people? But in our program, we look at it as a migrant as a whole is a person that has moved across country borders. So when we talk about migrants, we talk exclusively about international migration. When we are discussing internal movements, that's a slightly different perspective to take. So these numbers are from 2017. We have the 2019 numbers, and the numbers have indeed risen and a little bit, not significantly. It's still around 10% in the European region. Migration is, as has already been pointed out by previous speakers, a phenomenon that has been a global dynamic that we have seen throughout the ages. It is not a new phenomenon, it is not a phenomenon to be scared of, and it's not a phenomenon that we should expect will stop anytime soon. And that is the perspective that we come with from the WHO, and certainly also the angle that we take when we talk about policy implementation for long-term strategies. So on this slide, you'll see the blue marked section is labor migration, which is the main form of migration that we see from the Central Asian countries in the region. And this is very much a circular migration pattern that we see, which is associated with certain risk factors that I will get into later. When we look at the red and the yellow boxes or countries marked here, this reflects the recent large arrivals or large movements of refugees and migrants in the southern EU member states, such as Italy, Greece and Spain, as was pointed out earlier, and of course also Turkey. The green box reflects the type of migration that we've always seen. It's sort of an interregional migration, but it's definitely something that we also have to take into consideration. So looking at external migrants coming into the EU is not enough. We have to also be very mindful of the migration that goes on within our region and certainly also within the EU, because migrants within the EU also have a specific set of needs that is sometimes overlooked, such as access to healthcare. Despite having on paper access to healthcare, it's often a matter of not understanding health systems, not having the right cultural mediation, etc., etc. So, as we've seen the movement not only in labour migration within the eastern part of the region, but also the large influxes that we've seen since the beginning of the 2010s, we also have seen a shift in demographics. And this shift in demographics is something that we have to take into account because previously what we thought of as a migrant was a healthy young male, but now we see that we also have to very much more look at child and maternal health. We have to look at non-communicable diseases because of the length of time that people stay in the region, and certainly also we have to look at older migrants and their health needs too. So, what are the tools that we use when we discuss refugee and migrant health in the WHO European region? Well, in the center of this slide we have the Strategy and Action Plan for Refugee and Migrant Health. This is our main working document from what we do in our day-to-day work. It was adopted unanimously by 53 member states of our region at the Regional Committee in 2016. It was developed in large part by the program that I work for with Dr. Santina Severoni, spearheading it together obviously with our regional office and many other partner organizations. The Strategy and Action Plan is a set of 9 strategic areas that all point towards different aspects of migration and health and how we may strengthen health systems indeed, communications, data and evidence gathering, how provision of care is taken into account in member states as well. This document formed the basis in large part for many of the discussions when the Global Compact for Migration was taking place, which most of you will know was adopted last year in Marrakesh in December of 2018. And the working together of all of these initiatives, including the UN Sustainable Development Goals, is obviously instrumental in how we sort of attack this challenge that we're facing. The World Health Assembly then asked the WHO again to try to develop a world-spanning, a global action plan that could materialize the ideas and the goals that we have had for the European region and the strategy that we had developed here. Unfortunately, whereas the Strategy and Action Plan for the European region is associated with 9 strategic areas, it's also associated with 5 indicators. Now, as you all know, most of you within academia, indicators are a vital part of the work that we do in order to follow up with the implementation of the documents that we work with and indeed the effects that it has. Unfortunately, the Global Action Plan is not, as of yet, associated with any indicators, but it is an action plan that has been noted at the World Health Assembly this spring in May, May of 2019. So we do now have a Global Action Plan as well. The Migration and Health Program where I work is based at the European Regional Office in Copenhagen. We are the first and only fully fledged program that deals with migration and health at the global level. We have, of course, focal points and counterparts in other regions, but we are at the forefront of the not only the research and evidence that is going on within migration and health, but also a lot of the policy development work that I mentioned earlier. Advocacy and communication is a large part of the work that we do, and then the technical assistance. Now, advocacy and communication is not only outside communication such as this, it's not only advocacy with other agencies or indeed with the general public, it's also advocacy within the WHO, because there's still a lot of work to be done, not only in the way that we discuss refugee and migrant health, but also learning more and more about the evidence base that we have and implementing that into all aspects of work in the WHO. As again, I said 10% of the population living in our region is a refugee or migrant, so it should be in there in all of our work. Health information research and training, that's me. I am the focal point at the program for this. I coordinate all of our publications. We publish HEN reports, which is Health Evidence Network reports. I highly recommend that you go in and look at them. They are small, very easy to read summaries, reviews of the available evidence on a particular topic. They are meant to be a very brief but comprehensive sort of boiling down of facts and policy recommendations for policymakers and high-level decision makers. We also publish technical guidances, which is obviously much more for the day-to-day use. There's a lot of useful information. We've done to date 9 technical guidances on a variety of topics, and I would also recommend that you look at those if you're interested. I'm also responsible for our collaborating centres, and this is collaborating centres are a very, very big part of the capacity that we use. We are a small program. At the moment we are only 2 technical officers and our director, where we try to take care of this very, very large body of work. So our collaborating centres are indeed very important to us, and our collaborating centres are academic institutions that we work with through a process of 2 years where we do academic work together, and then an institution is nominated and becomes a certified collaborating centre with the program. Now we produce a lot of very, very good evidence, and we also produce a lot of outputs that we use not only internally but also externally. And it's interesting to see the growth and development. At the moment we have 5 established collaborating centres and 5 pending. And the network within academic institutions is interesting to watch as well. I know that our collaborating centres are now for themselves setting up a consortium as well. Then we work with technical advisory groups where we have obviously input from the academic world as well, from policymakers, refugee and migrant representatives, etc., etc. The technical assistance is the work that we do not only as a clearinghouse in-house, as I mentioned earlier, where we look through documents, we make sure that the language is correct and that refugee and migrant health is included in all of our products, but it's also at the country level. Now the work that we do here is more or less the start of the program. In 2011-2012, the program was established as a project, and the project was really to do with going out and doing country assessments to look at the large influx. At that time we called it influx, we don't like to use that word anymore, we use large arrivals now. Large arrivals of refugees and migrants and the capacity of healthcare systems. And we went out and did country assessments and gave a very brief, very short, very concrete report with actions for member states. And those are very interesting reading. You can also see the development from the beginning when the tool was developed to the output that we have now. And member states are very, very happy to invite us to come in and do these. There are diplomatic issues that we have to sort of navigate quite sensitively, but it is very, very interesting and important, not only for us, but of course also for the member states and ultimately for the health of refugees and migrants. So, the program was mandated by the regional committee in connection with the adoption of the regional strategy and action plan to do a basic baseline census of what is going on in the region. And this is a 3-time process that is going to go on with a progress report where we measure the implementation of the regional strategy and action plan. And we are currently now in the 2nd cycle, so I'm at the moment sending out questionnaires to our 53 member states to look at the implementation of the strategy and action plan. And in connection with that, we decided to try and gather the information as a baseline of evidence that we have on the health status of refugees and migrants in our region. And the result was that we looked at migratory trends in the region, we looked at the health profile that you would associate with a refugee and migrant, and I can say as a spoiler alert, this is complex. There is no definitive health profile of a refugee and migrant. There are certain risk factors associated with migration, but it is such a diverse group that it is almost impossible to say that there are specifics that we can associate with being a refugee and migrant, but we can certainly say that there are risk factors, and we see trends and some evidence. Healthcare organisation and delivery was a big part of what we wanted to investigate, to see how the different member states in our region have not only implemented the regional strategy and action plan, but what was currently there in their national plans. And then obviously to measure the progress in the region, which is also part of the second follow-up that we're doing at the moment. So baseline data on migration and health in the WHO European region shows that migrants and refugees are likely to be healthy in general, and often even healthier than host populations in the early stages of migration and displacement. Refugees and migrants appear to have lower prevalence rates for many non-communicable diseases on arrival compared with host populations. However, the prevalence rates and especially obesity begin to converge the longer that we see refugees and migrants staying in our region. Now, there's a multitude of reasons for this. It can be either being in refugee settings where there's not availability of healthy nutrition, there's a lack of access to healthcare, there can be detention in some cases. There's a multitude of reasons. Lack of integration obviously is also a big part of that. There is a health risk, so that was to do with lifestyles, and over time inequalities and health risks inherent to migration status can emerge. Refugees and migrants in general have a higher incidence, prevalence and mortality rate for diabetes than host populations, although they have a lower risk for all forms of cancer except cervical cancer. Unfortunately, we do see an elevated mortality rate for cancer because there is later diagnosis, unfortunately, and sometimes lack of access to care. Mental health issues is something that we often discuss. So depression and anxiety tend to affect refugees and migrants more than the host populations, as they're exposed to risk factors during all phases of the migratory phase. However, variation by migrant group and the methods used to assess the prevalence of mental health make it very difficult to make real comparisons across the region. Unaccompanied minors was another of the outcomes that we saw, are vulnerable to sexual exploitation and experience higher rates of depression and symptoms of post-traumatic stress disorder. So I've just taken a couple of examples for the health profile that we have been able to gather data and evidence on. And this map here shows the percentage of cases of foreign origin among total number of diagnoses of tuberculosis in member states of the WHO European region. Now, tuberculosis prevalence in migrants and refugees is likely to reflect the rates of the host country. When refugees and migrants arrive from countries with high prevalence of tuberculosis, they are at greater risk of infection depending on the conditions they experience in the country of origin during their travel and living and working conditions in the host country. So being a migrant is a risk factor for tuberculosis only if you come from countries with high endemicity already. This is another example where we look a little bit more at the healthcare organisation and delivery of healthcare. Member states of the WHO European region with a national immunisation programme that includes refugees and migrants. So as you can see, this is quite a static picture. There is a lack of data for a large part. And this is part of what we're working with within the regional strategy and action plan as one of the specific strategic priority areas as well. So this is from the first round of progress that we measured in 2017, which was published last year in 2018. And we've done a number of different questions. I've chosen to highlight these two as examples of what we've been looking at with our member states. So the first pie chart here on the left, has the member state developed a regional or national contingency plan for large arrivals of refugees and migrants? And of the 53 member states that we have, 40 member states answered our questionnaire. And you can see that 26 of the member states, in fact, have national contingency plans. Now, this doesn't, of course, say anything about the depth and breadth of this contingency plan, but it's certainly a place to start. And I like to see us as a small program, the train that could. We are very happy to see any kind of move forward because it is a place to build. The second one is, does the member state routinely collect and include data on migration-related variables in the existing local, regional or national data sets? And only 50% of the respondents, so far less than 50% of our total 53 member states, actually collect and include data on migration and health-related issues. Now that's a huge problem. That's a huge problem for us. It's a huge problem for many of you within the academic world, because without reliable data, we really have a very, very long way to go in ensuring that we provide evidence-based and evidence-informed healthcare to refugees and migrants. So the current gaps in migrant health data in the European region, which is the strategic priority area 9 of our action plan, shows that there is a lack of scientifically valid and comparable migrant health data throughout the European region. We have a lack of data on vulnerable groups such as irregular migrants. There's a lack of data that is disaggregated by sex or gender, migration status and age. And there's a lack of data on overall health status. Many times when we look through national registries or specific disease registries, that is where we find some kind of reference to refugee and migrant health. Unfortunately, that doesn't give the holistic picture of the person entirely. So, once again, we have to talk about definitions. What is a migrant? What is a refugee? An asylum seeker? And who do we include when we disaggregate this data? Another gap is on the geographical distribution that we see across the region, but that's not something that we have looked into very much more at this stage, but is something that we're planning to do with the next round of progress report. In connection with this, I'll just say that we've now published an entire HEN report, as I mentioned earlier. The Health Evidence Network report is called HEN 66. It is entirely to do with the availability of health data and evidence across the region. And it's an interesting read if you like that sort of thing. So, the report that I've mentioned, which is this blue report, is what it looks like in case you come across it. And obviously the strategy and action plan. So I've just highlighted two specific areas. The report points out that we need more systematic research in order to provide quality healthcare for refugees and migrants. And this is strategic priority area 9. And then we discussed the limited access to health systems, which is sort of the next topic that I'd like to take up during this talk, and that's strategic priority area 2. Now, the report found that obviously we are familiar with these obstacles to accessing healthcare. There's structural obstacles such as language, financial hurdle, where we see in many of our member states, unfortunately, that refugees and migrants have out-of-pocket payments for healthcare, which is a very large obstacle to accessing healthcare. We have legal frameworks that we have to discuss, and then entitlements as well that go hand in hand. Then we have the obstacles on the part of the providers. So capacity is a large issue that was also mentioned previously by John Ryan. Do we see the capacity that we need in the health systems across the region? And sometimes yes, many times no. That's why we're here, to help member states to develop their health systems in order to increase their capacity, and there are many ways of doing that. Then we look at language. Language skills is not only on the part of the refugee and migrant. We no longer talk about integration in the way that it is always on the shoulders of a refugee and migrant to integrate into the new society. We talk much more about inclusion. And inclusion means that host countries also have to take on the responsibility of hosting large populations of refugees and migrants. And so having understanding and cultural sensitive healthcare provision is a large part of ensuring that refugees and migrants indeed do have their human rights fulfilled in the sense that they have access to high quality healthcare that they are able to understand, comprehend and use. Now, the report showed that today member states are divided in terms of health system access into three major groups. Only emergency healthcare that's provided, emergency plus, where there are a few extra services such as maternal healthcare, and then full access to health systems. And from the WHO side, we like to advocate obviously for full and equal access. These are a couple of our technical guidances that I mentioned earlier. The aim with technical guidance is to inform and provide technical guidance or advice to policymakers and decision makers on areas of migration and health. We've seen recurring themes that have come out of the report that we've tried to cover to the best of our ability with the evidence available, and certainly also by working together with other research institutes and institutions to get an evidence base that is enough that we feel that we can go out and make policy recommendations. So, as I said at the beginning of the talk, we don't have a health profile that is definitive for a refugee and migrant. It is a very, very diverse group, much more diverse in many cases than the national host populations. And what we see is that there are specific risk factors associated with migration. So at the pre-migration stage, we have conflict, persecution, violence, discrimination, poverty, along with a whole host of other issues, of course. During the journey, we also see violence again, trafficking, smuggling, exploitation, slavery, and death. Now, death for most of you, if you are all within the medical community, is a health outcome. Arrival, detention, discrimination, family separation, limited access to healthcare, poor housing, lack of access to other services. This is a matter of discussing health not only from purely the health side, but looking at all determinants of health. It's looking at the right to health. The discussion at the moment, very much in my impression, is also the right to work. That's a discussion for the ILO. I'm not going to jump into that one, but it's certainly interesting that we are now beginning to see this complete integration of how we look at health for all aspects of life. Low levels of integration or inclusion, the disadvantaged socioeconomic positions in a country of destination. Now we know that many refugees and migrants end up living in places that are poverty-ridden, they are poor housing, again talking about determinants of health, and that's one of the reasons why we have to have a holistic, integrated approach to how we look at the health of refugees and migrants. Finally, I'd just like to mention the GPW 13 and the 3 billion goal. So Dr. Ghebreyesus, when he took over as the Director General of the WHO, wanted to implement the 13 General Program of Work, that's the GPW part, which runs from 2019 to 2023, so we are currently in this program of work. Now, this program of work builds on what is commonly known as the 3 billion goal. These are 3 strategic priority areas: achieving universal health coverage, as was mentioned earlier as well, addressing health emergencies, and promoting healthier populations. Refugee and migrant health fall within all 3 of these. Looking at the health and the health provision for refugees and migrants as an emergency is not true. It's about 10% of the work that we do. We look at the non-communicable diseases, we look at the health systems, we look at policy, long-term integration of migrant-sensitive policy into the national legislation of the member states that we look at. Refugee and migrant health is an emergency only in 10% of what we deal with. And referring to refugee and migrant health as an emergency or a crisis is not helpful. This is the diagram for the 3 billion goal that I discussed earlier. So from our side, there is no public health without refugee and migrant health. There is no universal health coverage without refugee and migrant health. If we want to live up to the 3 billion goal, we have to take refugee and migrant health into consideration, particularly because it is 10% of the population in our region. Thank you very much.